Bismillahirrahmanirrahim. Thanks GIC board for this kind of invitation. Our case today is 65-year-old male patient presented with unstable angina since 4 months. History of dyslipidemia and smoker. Heart examination was normal. ECG, there is no ischemic changes. Echo, there is no regional wall motion abnormality. It was planned for the diagnostic coronary angiography. Start with the coronary angiography. The LAD shows non-significant lesion, atherosclerotic with non-significant lesion, and there is an intermediate lesion, the mid-LCX at the bifurcation with a marginal. This is a spider view. There is a bifurcation lesion, and then the RCA, there is an tight subtotal occlusion of the distal RCA. So the operator decided at that time that to do the PCI RCA and to do an FFR to the LCX in another session. So what they do is done a transradial approach, GR4 guiding catheter, 6 French, BMW wire, pre-dilatation by balloon 2.5, 12 millimeter, and then upon a stent, dilating stent 2.75 at 32. And this is the final result. Then it was planned to transfer to our hospital to do an FFR to the mid-LCX and to do an control angiography. We done the control angiography to the RCA. But I would like to share with you the stent of the distal RCA. There is an under expansion of the stent. So we decided to post dilatation this stent before we going to do the post dilatation of that before doing the FFR to the LCX. So there is an under expansion, decided to do an post dilatation by NC balloon, 3 millimeter, 3, and then post dilatation by 20 atmosphere. It's easy. I think that when I put the NC non-compliant balloon, there is some resistance, but I think because the stent is under expanded. So what's happened here? I see a radio opaque shadow in the distal RCA. The procedure was complicated by a stent fracture. As designed by stent post, there is a stent fracture of the distal RCA. So there is a classification of stent fractures. The last one is the most famous one. It's classified according to single struts, so it's 2 struts. If there is a gap or there is no gap. And there is a predictors for stent fracture, technical factors, balloon or stent overexpansion, stenting technique, especially the crush technique, and appropriate handling of stent, especially the balloon inflation behind the struts. And I think this case is example of balloon inflation behind the struts. And also there is an anatomical and pathological factors, tortuous vessel, long vessels, and calcific vessels. So what we do next, the patient have a chest pain, we change for more support guiding catheter AL 0.75. We tried a lot with a guide wires, filter, whisper, and we successfully passed by the Gaia second wire with an aid of microcatheter. And then we tried to pass a balloon for post dilatation through this stent fracture. The balloon cannot pass. Kind of appreciated in the left video, the guiding catheter there is no support, there is not pass, and the smaller balloon at the right video cannot pass. At this time, we forget something important, that the stent is deployed at RCA and PDA, and we put our wire in the posterolateral branch. This is a problem. So we take another microcatheter, also failed Corsair Pro teleport, but the small balloons cannot pass, so we deal now with a balloon uncrossable lesion, so we need to increase the support. What we do, we change the microcatheter to the turnpike LB, and we rewiring through the post PDA, and we inject through the microcatheter, and then we successfully secured the Gaia second, secured the distal PDA with the aid and the help of turnpike LB. And then we change over the microcatheter by workhorse wire, BMW wire, and we dilate it sequentially by NC balloons put a 2DS 340 distally and 3.5 proximally. Then we are happy. We finished our work after 3 hours of trying to cross through this stent fracture. But the patient is a little bit hypotensive. So we take another last picture, and there is a distal perforation by the Gaia second. We decided to treat it by prolonged balloon inflation, 2 millimeter for 20 minutes. And it's successfully sealed by the prolonged balloon inflation. The patient goes to the CCU, there is no chest pain, there is a mild precordial effusion. Then the patient go after 1 month for doing the FFR to the LCX, and we make a control angiography to the RCA, and the RCA, the stent will well deployed. There is a lesion distal to the stent. There is no perforation, completely sealed. And then we do an FFR, which is positive, and we do a PCI LCX provisional stenting, 1DS 2.75 at 28. My take-home message is the stent fracture is a serious complication. We should learn how to avoid or how to learn. There are several predictors for stent fracture. Most important, inappropriate handling of a stent fracture. We should suspect a coronary perforation when you use a stiff guide wires. And the most important key message, we should revise the previous angiographic films before taking a decision for angioplasty. Thank you.
Excellent.